Good morning, good afternoon, good evening. It's a real pleasure to share with you some of my thoughts about the virological and pharmacological monitoring and in patients that will receive long-acting agents in HIV. So this is a slide about my potential conflict of interest. And this is the outline I would like to discuss with you. So it's divided into what we usually do now in 2020, what are some of the data we have in 2DRs, and then directly into long-acting agents. So this is taken from a few guidelines. As you can see from the first line, almost all of them suggest to monitor viral load as plasma HIV RNA every 3 to 4 months, and then up to 6 months in patients with a prolonged virological suppression. Genotype resistant testing is suggested at baseline, at failures, at other tests such as PBMC HIV DNA, genotype resistant testing on HIV DNA are suggested only in certain situations, and it's mostly as a research tool at the moment. Therapeutic drug monitoring is not suggested, it's not recommended by several guidelines unless for certain DDIs, for example, for DHHS guidelines in 2019. So if you move to virological and pharmacological monitoring in 2DRs, because it's most of the data we have now, I chose this poster at CROI 2020 by the Spanish group, in which I compared patients that remain on triple therapy to patients on dual therapy and those that went to monotherapy. I like this one because most of the dual therapy, as you can see in the box, are modern ones, such as dolutegravir plus rilpivirine. There is some dolutegravir plus lamivudine, and besides that, there are some older dual regimens. But I think it can tell us something about a real world of dual therapies. And in this case, you see that the risk of failure is not significantly different from those patients that remain in triple therapy. Well, this is because we probably chose patients to go on 2DRs, and therefore now we don't see an increased risk of resistance and of failure in patients on 2DRs. At AIDS 2020, there was also this interesting meta-analysis, was a network meta-analysis of dolutegravir plus 3TC. As you can see in the left column, there's no difference in terms of biological suppression when compared to other triple regimens. There's also some advantage against some of them. And there's also no difference in terms of CD4 change. On the contrary, there's some advantages in terms of CD4 recovery that need to be started. I think it's one of the interesting points to be started in 2DRs. Another important thing is also to take a look and see if, apart from the virological efficacy that we, in this case, are the clinical trials, you see a very good level of virological suppression, if there's any hint of an increased selection of resistant associated mutation. As you can see here, in all the studies, including SWORS, TANGO, ASPIRE, and GEMINI, there's almost in all the studies, just only 5 patients presenting with resistance associated mutation failure. So the risk doesn't seem to be increasing as compared to patients that stayed on triple therapy. What about pharmacological monitoring? Well, TDM was often used with older drugs where we had low exposure and we had a correlation between high concentration toxicity. So at this time point with modern 2DRs, I think it's seldom necessary. It can be useful in certain drug-drug interaction in which we need to study both antiretrovirals and concomitant drugs. In terms of symmetry, as you can see here, if you compare dolutegravir and intracellular triphosphate lamivudine, you see that they're almost comparable. So in terms of patients stopping the combination, you see that both drugs tend to decrease over time at the same page. And it's very similar also for dolutegravir and rilpivirine. That suggested that this symmetry may prevent the selection of resistant associated mutation because of functional monotherapy. Let's move then to long-acting. Most of the data we have now comes from randomized clinical trials, and we know that it's not real life, so some of the data are very clean, but we probably would like to have more data in real life, and we will just gather them as soon as they get to the market. So from all the studies, I put on the same slide the FLAIR study, the ATLAS study, and the ATLAS-2M, you see that long-acting cabotegravir and rilpivirine have a similar efficacy as compared to the other arm of the studies. And the ATLAS-2M, the comparisons between the drugs administered every 4 weeks over 8 weeks. And you see that virological non-response is pretty low in all of these studies. But I wanted to just take out the number of patients from all these studies, including Latitude, that was on the previous slide, that stopped, discontinued long-acting cabotegravir and rilpivirine for virological failure. And you see, if you put all these studies together, only 22 patients out of almost 2,000 participants. So for a real prevalence of virological failure around 1% is what we know now. It might change in the future because we will probably enroll different patients in real life. But at this time point, we know that the rate of virological failure is really low. So in the next slides, I will try to take a look at when these virological failures happen and in which patients, in order to give us some ideas or when and how it's better to monitor for virological efficacy and loss of response. So in the latest study, you see if you compare the drug given every 4 weeks to the drug given every 8 weeks or the drug given orally, you see that it's just only one patient has selected mutation, both an RTI and integrase. But I think it's also important to note, it's in the B line there, that one loss of efficacy was observed at week 4 and week 8 with no rilpivirine that was actually found in this patient. So in this case, maladministration of the drug was one of the possible explanation for this loss of efficacy. If you then move to ATLAS and FLAIR, you see that only 6 patients failed at 48 weeks. And interestingly, in the ATLAS study, you see that 2 patients, the first 2 lines, already had some baseline resistant associated mutation in the transcriptase and are mutation that confer resistance to rilpivirine. And interestingly, at failure was no selection of resistance in the integrase. In other patients, another 4 patients, there was no resistance at baseline and the selection of both resistance in RT and integrase. Some of the key factors here is the geographical location. Most were localized in Russia, and also genotype. Genotype was almost all genotype A and A1 that could be relevant for a potential selection of polymorphisms and then the selection of resistance. But what happened after 48 weeks? Well, we don't have much data on that. We have data from Latitude, in which the study went to up to 2 years. And you see that there's only 1 patient and 3 completed that had resistance selected at failure. And it was the same at 48 weeks. So no further selection of resistance after 1 year. And it was the same in FLAIR. As you can see here in the red box, you see that after 48 weeks, that no other failure. So probably all failures were observed in the first 48 weeks, and I will judge that mostly in the first 12 weeks. So probably at the start of the long-acting therapy and intramuscular administration of these 2 drugs. We also have very recent data at CROI last year of the ATLAS-2M. Again, the patients with virological failure were pretty low in terms of number, 1.5%. Only 8 patients actually had the selection of resistance associated mutation. And I think it's interesting to just take a look at the small lines from the study, in which some of these patients already had mutations that confer resistance to rilpivirine at baseline. So in this case, this analysis was done on PBNC HIV DNA that actually is telling us that patients are archived mutation before starting treatment. So I think at this time point, this kind of test is just for research, but it could be an option in patients that we judge a high risk of failure because of being exposed to NRTIs in the past, so we don't know if it's selected or not mutation associated with resistance to rilpivirine. I think I mentioned these because from ATLAS and FLAIR, we noticed that all patients had genotype A. So genotype A, in genotype A is apparently the polymorphisms in the integrase gene L74E seem to be much more prevalent. You see here in one of the studies in which 70 to 84% of patients with genotype A had the polymorphism baseline. However, from the analysis you see in the larger box here, there is no impact on virological suppression of 48 weeks. So it could be one of the elements, genotype and this polymorphism, but in the clinical trials, we're not able to see any clear signal that could confer a high risk of failing. And I think also this is the one of the first real life data. It will present AIDS 2020. You see here 33 patients that started long-acting cabotegravir and rilpivirine as a compassionate use for several reasons. Well, actually, 5 patients out of 33 had incomplete virological response and stopped the treatment. I think it's interesting to note that some of them already had mutation in RT. And one patient, actually, the first patient 1 here in the first column, you see that actually the regimen was discontinued because of bleeps mostly. So viral bleep of 55 copies was the reason for interrupting regimen. So there was no real virological failure. The other had virological failure for several reasons, but we need to understand why this reason. But even in real life, numbers of virological failure were low, and they were mostly in the first 12 weeks. Just for the future, would it be different, our monitoring, in when we will have implant-based ARV? So the curve will be much more, let's say, plain. We don't know, of course. We probably will need to monitor in the first phase, where the drug concentration need to go up, and then they're sustained over time. So we probably need to check up more often in the first phase, and the last phase when we have to change the implant. But probably in the middle, there's not much risk in terms of virological failure in case we don't change the concomitant drugs, and it might be a potential DDI. The last 4 slides are on the pharmacology. And I don't want to get into DDIs because it will be the subject of another talk. I just wanted to show you that some patients have lower concentration of long-acting cabotegravir at the first administration. So most of the underdosing is seen at 4 and 8 weeks. And some of the factors that have been associated were BMI, in this case, low BMI, not high BMI, and gender. And this is also the data of 2 patients in Atlas, 2 patients in the FLAIR, 2 women, 4 of them were women. As you can see here in blue, purple, red, and green, these were their individual concentration at week 8 and 12. As you can see, they were within a 90% interval for most of all of them, although both patients with the blue and purple curve were very, very low at week 8. And almost all these participants, 3 out of 4, had a BMI above 30. So this is not the only reason probably for these patients failing, but it could be one of the point in adjunction to genotype and polymorphism that might explain why. And I think the data on PK we have that can be useful is the tail. So what should we do when a patient come late for the injection? And I think this is an interesting study presented last year. You can see here in this table how high is the percentage of patients with an exposure of cabotegravir below the threshold after 4, 6, 8, and 12 weeks. And in the column, you see that if the injection delayed is the 2nd, 3rd, or the 4th. So once we are beyond the 3rd injection, we see that even with some delays, like say 4 weeks of delay after the 3rd injection, we still have patients with 90% concentration above the threshold. So it's kind of safety signal in terms of forgiveness. And we also have some bridging strategies. I think it's the same poster and tell us what we can do in patients in case they are delayed. We can use oral cabotegravir in order to compensate for this delay and then go back to long-acting agents. There's some modeling and some tables that can guide us in this term. In this case, we can also monitor how low is cabotegravir in the polls probably, and this might help us in choosing the regimen for restarting these drugs. And so I think it will be very important to change the organization of our outpatient clinics. You see here when patients have to see a physician, a nurse, a hospital pharmacist, just to see how it might change. Because now, for example, in Italy, we give the drugs every 2, in some surgery up to 3 or 4 months. We give patients the drug for their refill. So patients have to come every 2 months and will be similar to receiving an injection. And on this table, I also put my personal suggestion on where we should monitor HIV RNA after the start of long-acting agents. I think, of course, baseline, probably at 4 weeks, 12 weeks, and then we should go back. We probably can go back to 3 months and then maybe 6 months after 1 year. And just for research at this time point, we need to see the larger results, probably genotype testing on HIV, PBNC DNA to tell it, just to be more sure about the selection, previous selection resistance in our patient. So in order to conclude, I think modern treatment regimens are not associated with an increased risk of virological failure and selection of resistant associated mutation. So from this, we take the parallel to long-acting 2DRs. The data we have now at the moment from clinical trials suggests they're not inferior to oral therapy. And now we also have the comparison every 2 months. Virological failures were around 1%, with very few patients selecting resistant associated mutations. Most of the failures were pretty early in the first 3 months. So probably monitoring should be closer in the first weeks. We have so far an incomplete knowledge of risk factors, genotype, polymorphisms, pre-existing ramps in NRTI might be a factor, so we need to see more data on PBNC genotype. And PK may matter in certain patients. We need, again, to get more data in real life in patients according to the gender, BMI, and potentially, if we have a patient maybe with previous exposure to NRTI, we have a high BMI, genotype A, and so we might want, for example, to extend the lead-in order to cover the first injection that might be slightly underdosed. So I think PK may be useful in very selected patients. So I thank you for your attention. Have a good day.